So for anyone joining us last minute, I'll give them a courtesy of another minute. But while I have your ear, I'm Dr. Larissa Schmidt, and I'm the current president of the Florida Podiatric Medical Association. Thank you all for taking the time to participate in this discussion. Definitely think there's going to be some great take-homes, great points, looking at it through quite a few different lenses. For this evening, really would love to thank our co-sponsors for PICA, creating this opportunity for a real education set and providing great care for our patients, and you know, the necessary needs of the communication strategies for more complicated cases. Just for some housekeeping items, if everyone is aware, this is our Zoom, so please make sure that you mute your microphones. If you do have any questions, please raise your hand. Also, there will be some discussion points labeled throughout the PowerPoint, so we'd be happy to tackle questions kind of within that set. So you don't necessarily have to wait to the very last minute or lose any train of thought throughout this process. Couple other items, if you have not already, please take the time to register for our SAM conference. It's going to be very engaging, very exciting this year. The exhibit hall is going to be fantastic as usual. The theme this year is the greatest show on earth. So if you can imagine our creative juices flowing in that endeavor, we're going to have a really great time with all of you. SAM this year is held January 29th through February 2nd. And that will be taking place at Disney Coronado Springs. I believe I heard the hotels are almost halfway full. So if you have not obtained a reservation, please take the time to do so. All right, so without further ado, we're going to go ahead and kick off this engaging webinar. As you can see on your screen, the topic for tonight is really thoughtful. Basically, it is the communication of complication risks with advanced surgical procedures. And as you can see, we have a host of lectures. And so I think that from all of our viewpoints, we're all going to have some very fruitful take-homes. I'm going to announce our starters here and hopefully giving you a little bit of their background, their experience, and also the opportunity to reach out if you have any additional questions. Our physician lecturing this evening is Dr. Timothy Miller. He's a dual board certified surgeon, certified by the American Board of Foot and Ankle Surgeons in foot surgery, as well as reconstructive rear foot and ankle surgery. And he is also certified by the American Board of Podiatric Medicine. He's an expert in lower extremity deformity correction, limb salvage procedures, and trauma of the lower extremity. He holds certifications in orthoplastic and microsurgical techniques of the lower extremity, including peripheral nerve repair. He holds additional certifications in arthroscopic surgery of the foot and ankle, along with total ankle joint replacement. He serves in multiple state and national leadership roles, including with us here in Florida. He has had national publications and has presented on local and national levels. So that's our kickoff speaker. Additionally, if you can see on screen, we have a couple other guests with us this evening. We have Mr. Wilbert Van Kool, who is a graduate of the University of Florida, so go Gators, as well as the University of Florida Levin College of Law. Will currently represents healthcare providers, hospitals, and government entities in a variety of malpractice and complex litigation matters. Aren't they all, Will, right? Additionally, Wilbert practice includes representing clients in administrative matters and appellate actions. Currently, Wilbert serves as co-chair of the Medical Malpractice Committee with the Florida Defense Lawyers Association. Will is active in the community and volunteers as youth basketball and soccer coach at the downtown Orlando YMCA. He has also served as a member of the Board of Trustees for the Orange County Library System. Wilbert Van Kool was invited to become a shareholder on January 1st, 2024, and the firm will now be styled McGowan, Martinez, Dukes Hall, and Van Kool, PA. So congratulations there. Okay. All the claps. You can't hear them, but I see all the stars shining. Okay. And finally, rounding out our host of winners here, we have Dr. Luke Ciccinelli, who you all hopefully know is the Chief Medical Director of PICA with over 30 years experience, both domestically as well as internationally, as a podiatric surgeon, consultant, speaker, and educator in sports medicine, reconstructive surgery of the foot and ankle, and diabetes limb salvage, including 28 years as a lead surgeon on humanitarian missions in pediatric surgery in Central and South America. His wife, Dr. Van Roman, DPM, is also a podiatrist, and they have worked together in private practice as he is a consultant surgeon in multiple clinics throughout the US, Spain, and the European Union, as well as Saudi Arabia and Australia. So good day, mates. With that in mind, again, thank you for listening to me. I will be trying to voice and see anybody who might have questions throughout. But with that in mind, I will go ahead and kick it off to Dr. Tim Miller. Thank you all.
Awesome. Thank you so much, Dr. Schmidt. That was a fantastic introduction, and I am really excited to be here. I think it's a fantastic topic that we're going to be speaking about tonight. We have a couple of different panelists with varied backgrounds, all experts in their field, and something that we can really offer our listeners and beyond. So I appreciate everyone being here. I know schedule-wise, clinic-wise, patient-wise, it gets difficult at times, but I sincerely think this is worthwhile, and I'm again really excited to be here. So I'm Dr. Tim Miller. I practice in Orlando.
Okay.
I graduated from NYCPM and I did my residency at Morristown Medical Center in Morristown, New Jersey. From New Jersey, I went to Ohio and I completed a lower extremity recon, limb salvage, and trauma fellowship with the foot and ankle specialist of Ohio. And that's where I gained my niche.
It's pretty big and
Just a quick announcement. If you guys can mute your phones or mute while we're speaking there, because we're getting some feedback from some other ones. So thank you guys. Awesome. Perfect. So, and that's where I gained my niche and my expertise in a lot of these complicated cases that we're going to go into today. And, I learned a lot of what to do and a lot of what not to do. And that's really what has shaped me and was helped me become what I am today. And I'm still learning of when I deal with these complicated cases, when things get even more complicated than you anticipate, and how to make that better. And that's really what the goal of that is tonight. So currently I practice with my wife. My wife is a podiatrist too. So Dr. Ciccinelli and I have that bond there that we like to inbreed in podiatry. But I'm a co-owner of Sunshine Ankle and Foot Experts. And I'm going to kick it back over to Will here, and he's going to do a little more introduction on himself.
All right. So I received a fairly thorough introduction. My name is Will Van Cole. I've been practicing since 2011, almost exclusively medical malpractice defense work. My firm does, I'd venture to say, 95% plus medical malpractice defense. So both administrative as
what is expected of me at that time, and am I receiving what
I think there's okay, there we go. And so I do both administrative as well as litigation related matters. Fortunately, I've been blessed to have an opportunity to lecture a good amount and give some thoughts as it relates to some risk management issues, as well as what I see in litigation. No one really wants to see me, as much as I try to be a nice person. No one ever really wants to see me, but I understand the difficulties and the risk associated with practicing, especially in Florida. I've lectured, and every time I lecture, I say in Florida, it's more of a question of when, not if you're involved in litigation. Unfortunately, it's just a litigious society. Just so if you guys aren't oriented with Orlando, I am across the street from the public library, and literally I can look and see the Morgan & Morgan building, the biggest personal injury firm in America. So that's what Florida has to offer. So just to give you guys a heads up. So I look forward to helping out and presenting today.
Awesome. And then going to kick it over to Dr. Luke Ciccinelli as well too, to kind of.
Thank you, everybody. Appreciate the introductions of all. I don't need to, no need to repeat any of that. I just want to thank the FPMA for the collaboration as well and hosting this with us. Dr. Miller and Mr. Van Call. And Will, you just said something that really, I think, is what leads this off for me as a great topic for discussion, and the when, not if. And our real emphasis is around proactivity and trying to stop trains from going off tracks, creating good habits of risk awareness, and really back to the title that Larissa mentioned at the outset, it's really about the communication of the potential for complications around these complex procedures. And so if the reality really is, it's not a matter of when, it's a matter of when, not if. That's what this is all about. We hope tonight's session will help everybody think proactively in the communication with patients around more complex procedures, and particularly as folks are exiting residencies and fellowship training, and in that first 1 to 3 years of private practice, the perhaps nuances and wisdom of skills around communication with not only patients but their family members about potentially things that could go wrong, how to address them, of course, but hopefully how to avoid them. So thank you all very much. Let's kick it back to you, Tim. Thank you.
Awesome, of course. Well, thank you so much. It was the when Will mentioned the Morgan and Morgan, that's what, kind of we see those signs all over the place about injury. So I think, you guys both hit the point as well too. It's a matter of when and not if, and being proactive and talking about communication are two of the biggest things that we're going to be speaking about tonight. You can mitigate a lot of things by being proactive, and you can mitigate a lot of things being having that communication, developing those skills, and really spending the time. And that's kind of what I'm going to go into next talking about here. Now, we're kind of focusing on these advanced cases, like cases that I did my fellowship on that I really enjoy doing are muscle flaps, limb salvage procedures, reconstruction, significant trauma. So, and those cases, when you get more and more into the nuances, are complicated. They take a lot of time, they take a lot of planning, they take a lot of effort. And the more complicated a case is, the more complications are likely to arise. And even though we are talking about these complicated cases, it really pertains to all of surgery, right? There's basic principles that we really want to implore today and speak to you guys about and have discussions and answer your questions that can help from something as, more of a routine case upwards to a more complicated case. So again, really thank you all for being here. And that's when we're going into talking about communication. Communication is absolutely key. When you're planning a surgical intervention, something of a reconstructive surgery that is going to take a significant amount of time planning, that you have to, part of that planning is sitting down with the patient. Unfortunately, we're pushed into these schedules where, more and more patients, the faster you can see them and the faster you can treat them, the better it is, because then you can move on to the next patient. But when you're inheriting these patients, whether they're referred to you or from the emergency department, and you have figured out the plan of what you think needs to be done, you need to communicate it with those patients. So that's when you make sure in your schedule that time is allotted. Time is key. And I think patients that are referred to me when we're talking about these complicated cases and I'm the one that the doctor refers to, their biggest complaint about other physicians is that they don't spend the time. They feel like it's 2 or 3 minutes and that they're treated more like a number than an actual human being. And that's where a lot of times, at least in my experience, that these cases that could potentially go on to litigation can be avoided as long as the patient has felt like that they were heard and felt like that they were talked to as a person and not, not a thing. And that's really what I want to harp on. It's not a 5-minute encounter, and you have to make sure that your schedule has that adequate time. Also, consider, and Luke, Dr. Ciccanelli, you hit the nail on the head that including family in this as well too, because more often than not, there's a support structure around these complicated patients and these complicated cases. And the family really takes the brunt of the force. Now, granted, the patient has to go through the surgery, has to go through the recovery process, but there's family driving them back and forth to their appointments, back and forth to their physical therapy, getting their medications, making sure they're taken care of. Middle of the night emergencies happen, complications. It's not only falling on you, the physician, as the surgeon, and the patient, it's extending beyond that. And including the family is significant. Now, when I plan for a surgical intervention that is complicated in my eyes or something that's going to take me a significant amount of time, I always ask the patient to bring the significant other or to bring a person that is going to be helping them the most. That ones who, whether it's child, whether it's mother or something, that they come to the appointment. And if it's that they absolutely can't come to the appointment, then I have them on the phone, that they are there and I'm going over all of the risks and benefits, the complications with the patient and with that family member, because there are absolutely times that there is a high maintenance family member that lives in another state that is neighbors with an orthopedic surgeon or that is best friends with a medical assistant who's in an office of a different podiatrist that you do this surgery on and a complication arises and the patient tells that daughter and that daughter tells their best friend or tells their neighbor and the neighbor is like, well, I wouldn't have done that, I would have done this, or you could have done that, or and then all of a sudden things start to spiral, right? That patient during that recovery time spends a lot of time in their own head because they may be non-weight bearing or they have restrictions that you're imposing on them, and that sometimes they can be their own worst enemy and they're starting to come up saying, well, maybe I wouldn't have gotten that infection if you gave me this antibiotic, or maybe the hardware wouldn't have failed if you use this certain hardware as opposed to that, or this company versus that company. So it including the family is absolutely clutch, and I have definitely been doing that. And there are times I haven't done that and I have regretted it. And now it is my protocol that not only am I giving the time to the patient, but I'm giving the time to the family members as well too. Uh, so one of the things you can see here as well is first time versus how many times. Now, I think nowadays podiatrists are very well trained. I think most, if not all, residencies and most, if not all, fellowships produce very well trained surgeons. But not so much residency. I think more fellowship, especially because fellowship specializes in more complicated procedures, is that it's a point in time. Most of the fellowships out there are 1 year, right? So in that 1 year, you get those cases, but there may not be a specific pathology that happens that you now become an attending. You're out in private practice or out in whatever job that you have, and that case comes to you, and you know that that is what the patient needs, right? You've done your research. We're all well-learned doctors, but it it's something that you may not have done, or you may have done back in residency, and that residency year that you did that was 3+ years ago, or you've done it on a sawbones or on a cadaver. So it's the first time doing it on an actual live patient versus how many times. And when I don't think I look young, I guess, but when I shave, I apparently look much younger than I actually am. And I got a lot of grays going on. You can't really see it here, but
So
um,
Tim, you have started shaving.
I have, yes, I have. I've reached that point. I feel good about it. But it's I get asked all the time, how many times have you done this? And when you come out of fellowship, you get these, broad, you have this somewhat of an ego going on, and you're like, yeah, plenty of times. I'm good. We're fine. I'm trained in this stuff. But you get to a point of where you have to role reverse, right? And really take the mantra of do unto others in my patient care. And I really want to treat the patient on how I would want to be treated. And I've had significant medical events. My family's had significant medical events. And during or the preoperative planning of surgery, if someone didn't tell me this, that I had asked, that this was the first time they were doing it, and I found that it was after the fact, I would be really upset. And especially if a complication happened. So I think the being honest if they ask, telling there. Now it's something you don't have to volunteer unless you feel morally obligated to. But I think doing these complicated procedures, telling these patients that, yep, I've done this 100 times or I've done this 5 times, and then following up as long as you're comfortable with the case and you feel adequately prepared, that saying that, yes, I've done this 2 or 3 times before, but I know how to do this and I have no problems doing this. Showing that confidence, that's not a bad thing at all. But being honest with the patient, because honesty and communication at the end of the day is really what's going to save you from a lot of future headaches and future problems there. So I do tell patients if they ask me if this is something that have you done this before? And I try to estimate now, don't get me wrong, there are things I've done hundreds of times. So I'll say, yeah, it's in the hundreds or, maybe even the thousands. But if there's something that comes up like a more complicated thing, when I do muscle flaps, I take the peroneus brevis a lot. I think, and I'll deal with the tibialis anterior a lot, but there are some smaller areas that I haven't done too many times, haven't taken that muscle. So I'll tell them, I'll say, yeah, I've done this before, not as many as other times, but the principles at the end of the day of surgery are all the same. So, and that seems to comfort them a lot. So that's a point there I wanted to make. Going on to the next complication where complications can arise is the production numbers and the volume. There's our jobs that are out there that are RVU based, and the more pressure that's on you to get those numbers, the more likely you are to take on these complicated cases. Something that either A, may be out of your wheelhouse, or B, something that you're trying to do fast. You have these complicated case that's coming in, but you also have 5 other cases that day on your block day. So you can't spend that 3-4 hours that you need to, it has to be done in an hour and a half. And that kind of pushes you into a territory you may not want to be in. Speaking of these complicated patients as well, too, complicated cases, one of the things I want to harp on is don't be afraid to refer out, right? That's something that if you are not comfortable with the situation, not sure of how to handle it, refer out. Nobody's ever going to get down on you for referring out. So I know with these pressures, with these volume numbers that you have to meet, sometimes you don't want to, but it is okay. And then board certification pressure, right? There are boards out there that we have a certain number of years to get a certain number of cases. And sometimes if you're in an area or in a job that you're not getting those numbers and meeting that number or that diversity, sometimes when that patient walks in, you want to jump to it. You want to say, yep, in your head, you're like, I'll click this diversity, I'll get this number. That may push you into doing a case that may lead to more complications. So that's something that you'll need to be sitting for yourself and think about that. And if you want to accept that and go ahead with that. And, that's unfortunately, there's no way around it. That's every profession that surgical has those board certification numbers that we have to reach. So it's all of those boards there, but that is something that has to be taken into account that can, push you into a complicated patient and with a complicated case and lead to more future problems for you. Now, ethics, we talked about this before. There is an ethics behind these patients too, that with that moral obligation, right? You have this obligation to these patients, not only medically, but morally. So we talk to them first time versus how many times. And if that's something that they ask you, being honest with them at the end of the day is going to save you more often than not. Because If it's a patient where they're saying, you've only done this once before, they may not want you to do it. They may want you to be, or have you refer them to somebody else. And at the end of the day, you may be upset that you've lost that patient, you've lost that case, you've lost that RVU. But if it's better for the patient, that's something that's worth more than all of that. When we took that Hippocratic oath, it's that first is first do no harm. And if it's something that can lead to a complication that can lead to harm to a patient, you have that obligation to say, hey, listen, maybe I'm not the surgeon for you. And doing unto others, I do preach this. I preach this to my patients. I preach this to my colleagues, that if the role was reversed and you had that mangled foot, you had that ankle that needed to be replaced, you had that large wound defect that needed a muscle flap with an external fixator, would you want you to operate on you based off what you know, based off what you've done, based off your skills? And that's something that you'll need to sit and think about. And that all comes back to communication. That all comes back to the fact that when we're communicating with patients, feeling that, the preoperative planning about your skill set there, going back and communicating with them, if this is something I would do to myself or do to my family members, then I'd be comfortable doing it to you as well. So communication is key, what we've harped on before. And I know Dr. Ciccinelli and Mr. Van Cole are going to go into that as well too. The more you communicate, the better off you are. And documenting. And I cannot harp on the fact that the more you document, the more you include, the better off you're going to be if things go south. Now, I do legal work. I view cases. I do both sides of multiple cases, multiple injuries of the lower extremity, things that go south. And one of the things I've seen a lot of defendants get dinged for is horrible documentation. And I have read horrible notes, and one or two sentences for the plan for a complex flat foot reconstruction. And it's something that boggles my mind, because if you don't document it, that you've communicated with the patient, with the family member, then it never happened. And that documentation is what is either going to save you or harm you at the end of the day. So even though, listen, we see 25, 30, 35, 40 patients in a day, and it is incredibly tough at the end of the day, because it's tough to keep up with notes during the day a lot of times, to sit down and spend an extra 2+ hours sometimes writing these notes. But looking at it now, do you want to spend that time even more time dealing with a litigation case, or spend that time now, which would be less time, documenting? And to me, documentation wins. And now it's easier now, because a lot of times we'll have these quick inserts there, these templates there, and a lot of people are now using these dictation systems that work out really well, and those are all good. Just if you have those dictation systems with those templates, just don't blindly sign at the end, especially with these complicated surgical patients, making sure you're reading those over, making sure everything is documented. You talked about the risks, the potential benefits, the potential post-operative course, and that you answered all of their questions, and you spoke with a family member. And now I have, with my post-operative instructions, I have a document that I give to them, that they sign and give back to me, and I give them a copy of that document that they have, that is uploaded into their chart, that they sign, that they agreed to the post-operative stuff, post-operative instructions, and that they read it, and I gave it to them. And that's something that has saved me before, because people who don't listen to you post-operatively develop these complications there. Somebody may be chirping in their ear to say, hey, maybe you should take this the next step. But having that and documenting that I was given to them, that they accepted, that has saved me. So Document, document, document. It's the bane of our existence. That and insurance companies are the bane of any podiatrist. But at the end of the day, making sure that you document is key and is clutch. So these were really cool. When Luke, Will, and I met to discuss this presentation, Dr. Ciccinelli brought up a great point about competency. What is the learning curve for surgeons? What is the minimum number of surgeries that need to be performed in order to reach quote unquote competency? And these are two articles here that I highly encourage you to read, relatively recent articles that were published about numbers versus experience and complication rate. Now, basically summarizing these two, number one, practice is needed, right? Obviously, the more you practice, the better off you'll be. But if you haven't practiced it, one of the things we harped on when we talked before this, that if you haven't practiced it or you haven't done this, just letting that patient know, right? Not accepting that complicated patient unless it's known that, hey, you haven't done that. So that's something, harping on again. But numbers versus experience, obviously, the more numbers you have, the more experience you have, the more competent you are. And it was sometimes going into the different cases there, it was hundreds of times that needed to be done in order to be competent. And sometimes that's not feasible, especially in these complicated patients. It's something that can't be done unless that's all you do all day, every day. And some of these surgeons or the specialties that they went into, that's all they do is this surgery all day, every day. And it took a significant amount of time. But that's something that you need to be comfortable with. That's something that you need to feel that you can give to those patients and do unto them. So I think we're gonna pause here for discussion. I don't know if I'm sharing my screen, so I can't see the questions or anything there, but I think Dr. Schmidt is gonna kind of.
Yeah, I mean, I'd really like to open it up to Dr. Chick as well as Mr. Van Cole, kind of opinions on some of our thoughts. I know all of us as surgeons are kind of rattling the same really points and topics that Dr. Miller has dove into. So what are your all's
Well, so
response?
thank you, Lewis. I'll jump in there. So thank you, Tim. Great background discussion about so many things. And it leads me to a couple thoughts I'd like your opinion on, and maybe it can foster some discussion as well from anyone in the audience. So specifically around your preoperative assessment on what I like to call the psychosocial history. So whether we call it the social history, I prefer psychosocial history, and bringing in elements of the social determinants of health, specifically around these really complex procedures. So my question to you is, how deep a dive do you take on asking patients and their family members about certain things? And I'll tell you why I ask. I, on complex procedures, learned a long time ago two very important things. Depressed patients don't do well postoperatively when there's really long immobilizations and there's a lot of change in their daily or weekly or monthly routine. And I believe that is really critical to recognize on the front end. And then part of the social determinants of health about people's living arrangements, their economic means, their proximity to care, those types of things, but also how are their relationships with significant others. I've seen people get divorced while recovering from a complication from Charcot reconstructions of my own. I've seen a lot when there's discord in the air on those preoperative visits or some sort of psychosocial history. I'm very, very cautious. So I want to give that backdrop, and I'd love your opinion on that, and anyone else, including Dr. Schmidt or any other the people listening. I think those things are really important. Do you have an opinion on any of that? Do you do anything special? Ask any special questions? Decide not to do something because of those things?
Absolutely. I'll take the start on this one. Absolutely. And I think that comes into play when you speak with the family member as well too. When I ask, or the support structure, when I ask the patient to bring in the person that's going to help them the most, you evaluate the relationship there and you can kind of see things firsthand. Now, granted, faces can be put on, but talking about what can happen, especially in areas or times when non-weight bearing is at a specific amount of time or potential complications, you can kind of see eye rolls happen and you can kind of see,
Exactly.
exaggerated breaths or going huffing and puffing, and then you can kind of see whether or not that person is going to be there. And then on the flip end, you can see the supportive husband. I just did a complicated case on a patient recently. Beforehand, the husband was every step of the way, and everything that I see is very supportive. So that, number one, it's almost like the not so much the questions that I ask, but more of what I see with the interactions there, number one. And quite frankly, I asked the family member, can you handle this? Because it's something that is a burden on the patient, but it's a burden on them. And as you said before, it pushes stress and strain. So I always ask them, can you make sure that this patient gets what they need, does what they need to do? And I've had family members honestly say no, like say that this is too much, this is more than I thought it was going to be. And that's when we start looking at next steps of what we need to do, whether it's rehab or whether it's a different plan altogether.
Alternatives, always have alternatives.
Exactly. You need to, your backup plan to your backup plan. So it's something that really is crucial to the support structure of these patients. And I will ask if I always going into past medical history, I'm always looking at their medications with these patients. And if they are depressed or have anxiety, I actually have found, and I don't know about you, Luke, but in my complicated cases where I've had complications, I found the anxiety patients are tougher to deal with than the depressed patients. And I don't know if you,
But exactly. And perhaps there's a spectrum of just not being completely well, right? And it's okay not to be completely psychosocially well. I think we all recognize that. And so, whether it's anxiety, whether it's obsessive compulsive disorder, whether it's a, uh, a, a gradation of that, whether they're depressed. I think what I'd like to emphasize is we'll never know the answers to the questions that we don't ask. And what we have to do is we have to proactively ask questions that may seem odd to us, but can be very revealing on the front end so that we don't have complications, not just to protect ourselves, but to protect our patients, because it's their complication. I mean, it happens to them and it happens to us, but we're sort of, everyone sees the world from the seat they're sitting in, right? But let's be frank, right? We don't want anything to happen to any patient, and so we gotta be in front of it. So yeah, absolutely, anxiety as well, because they're not in a good situation to pivot to long periods of immobilization, so much disruption in their normal routine.
We do have
Yep.
a hand raised from Dr. Rabotsky, if you'd like to comment on this discussion point.
Sure. Thank you so much. Again, big pleasure. I'm kind of disappointed that the rest of the population of the FPMA is not participating in this, because I think that's a travesty. They're missing out on something missing out on something they really can use. Couple things that I think that just really stand out at this when you look at it. I put my camera on. There I am. Okay. You got to remember, there are no small operations. I think we got to take that into consideration. Every patient you cut with a knife is a big operation to them. And I don't think you want to distinguish this from one to the other. I'm sure our learned counsel on here will tell you that he gets as many complications for little stuff than he does for real big stuff. Real big stuff you spend a lot of time with. The second toe that doesn't sit straight. I get more attorneys sending me cases about second toes that don't sit straight than anything else. And I just tell them, hey, that's just part of surgery. Another thing I think for all the new people out there is not to self-aggrandize themselves. I have seen so many resumes and so many listings on web pages where they have 7 or 8 certifications. Well, there's really only 3 certifications in our profession, or really now 2 that are approved. So I'd be really worried about pumping your resume to look better than what you've actually earned, because attorneys love to tear that apart, even if it's well earned. You know, it's just one of those things. Having been the patient, I've seen the other side. And I'm sure at all this, one of the things I used to do is tell every patient the worst thing that can happen during their surgery is I die. They would giggle. And I would say, well, the second worst thing is you die. And I put, you know, it kind of lowers it. But if you tell them they're going to die and they get an infected toe, well, it's still not as bad as they're going to die. So you've set up a higher expectation. And I think that's it. I think these type of forums are wonderful. I think they should explore. There's a lot of wealth of knowledge of Dr. Zinkin and others I saw on this call with decades of experience. And I think that as a mentorship, maybe for some of the younger surgeons would help. And we're lucky we have Luke at the controls of what, you know, is the insurance company. But I'd ask him, are the big surgeries the ones that you see the malpractice claims about, or is the little nuisance ones that just cause aggravation? So with that,
Well,
Larissa.
so thank you, Brett. So you see both for sure. And there's no small surgery, there's no small complication, there's no doubt about it. But when you think about and the nature of the generation of this talk, the worst possible scenarios are larger here, right? So we're talking about proactively trying to avoid loss of limb, a case that could become a sepsis case, and a loss of life, and so forth. So, and then specifically, and will get into this as well, we also want here to be emphasizing, and Dr. Miller did an excellent job of it on the clinical side, the obligations, be they ethics, be they morals. And I'd like Will maybe to comment on that. Maybe in the other question, the Q&A, is there a difference, between ethics and morality about the decision makings that Tim talked about? How many have you really done? What if you're on the receiving side of some new minimally invasive total hip replacement or partial knee or something, so the same. So it's a bit of a different context here, I think, Brett, but absolutely your points are very well taken. But
I just add one last one, is I've seen 3 or 4 malpractice cases sent to me in the last 6 months or so, where the patient's chief complaint was one toe that was killing him, and the doctor did bilateral smashes, 4 toes, both bunions. But the chief complaint in the original notes was the 5th toe or the 2nd toe. And I know people are trying to get their numbers in. They're trying to earn a living, the reimbursement. I mean, I'm still a believer that foot surgery should pay as well as everything else. You should start out a residency at $400,000. We have to figure out how to get there, but we're not there yet. So people are trying to do as much as they possibly can to make a living. And I recognize the frustration. So that would be another concern, is just don't do more than they complain about, especially if that's what's in your notes.
Mr.
well,
Mason.
absolutely. Thank you. So let's, are there any more questions, Louise? I'm happy to hear more questions from any audience. If not, we'll continue on with Will Van Call.
Go for it, Will.
All right, I appreciate it. All right, so we can move on to the next slide if we can, Tim. So I want to talk a little bit about informed consent from my perspective. And this first slide I call the black and white of informed consent, because as complicated as informed consent may be, most states have a pretty well-defined statutory requirement or case law interpretation of what constitutes sufficient or satisfactory informed consent. And I sort of broke it down into the universal view, majority view, minority view. And the final question is, where does Florida fall within that spectrum? The universal view, which pretty much all 50 states that have interpreted either by statute or by case law acknowledge that certain things must be part of either the consent conversation or consent colloquy. One is sort of the nature of the procedure that's going to be performed. And the key part for informed consent, especially in Florida, and we'll talk about it a little bit, but pretty much throughout the United States, it is judged from a reasonable patient standard, which is would a normal, reasonable patient have an understanding of the nature of the procedure based upon what has been communicated to him or her? And that's sort of the threshold analysis that is done. So it sort of flips everything. I think there's a lot of talk about the obligation of the physician to communicate, which is clearly important. But part of that communication is the understanding of the patient. So there is a duty while you're communicating to make sure the recipient understands what is being told to him or her. Because even if you use all the appropriate words, but because of the person's mentation, because of their education, because of their lack of sophistication when it comes to medicine, if they don't understand, or a jury would say a reasonable person would not understand, then that is a failure of obtaining appropriate informed consent. So if we go back to it, the universal views, the nature of the procedure has to be understood, alternatives have to be communicated, and the risk associated with the procedure have to be communicated as well. Those are sort of the three key pillars that every state adopts as it relates to informed consent. When we met together, Luke, Tim, and I, when we met, the question was, where does experience fall into that? If it is a complex procedure and I'm out of residency and fellowship and I've not done it independently, if it's a relatively novel procedure that I've not really done independently, does informed consent require me to communicate my lack of experience? So the majority of view says no. It clearly says no. And I cited a case, it's not in Florida, it's a Washington State case, and it's back in 1997. And my guess the reason this is the case is because it's from 20 plus years ago, but dealt with a laparoscopic gallbladder removal procedure, a cholecystectomy. And the physician who was going to perform the procedure had never performed it on a human patient before, has the consent conversation, does not communicate the inexperience with performing this laparoscopic procedure. Procedure gets done, as you will expect, because there's a medical malpractice case, there's a complication associated with it. The common bile duct was nicked during the course of the procedure, resulting in a series of complications and a negative outcome. The lawsuit gets filed. Ultimately, the jury finds the doctor was not negligent in terms of the medical care that was provided, because again, I don't have all the records, but I can probably guess, because most of us have defended these cases, it's the nicking of the common bile duct is a known and recognized complication of the procedure. And so the jury accepted that. So the jury concluded the doctor did not do anything wrong in the technical performance of the surgery. But nonetheless, the jury found that the doctor failed to obtain informed consent because the doctor did not communicate he had not performed this procedure previously. And from the jury's perspective, they felt that that lack of experience was a material fact that the patient would want to know. So let me take a quick step back.
Will, excuse me, I want to be clear
Yeah.
because it's really important. This is exactly the part of the real crux that we wanted to get here. So that's the majority view. What you just described is the majority view experience.
No,
right?
no, that is ultimately, and this is where it becomes the majority view. Ultimately, the court says the lack of experience is not a material fact. All the material facts related to informed consent are those risks inherent within the procedure. So
Oh,
the appellate
okay.
court actually ends up rejecting this argument and overturns the verdict and says there is no violation of informed consent because your lack of experience is not material. It should never have been an issue the jury should have considered. So the
Gotcha.
majority
Okay.
view is it does not matter. So, but I did
Okay.
want to point one thing out which may not be clear from the explanation. And I tell folks this all the time. There is a difference between a medical malpractice case and a case based upon lack of informed consent. To prove a medical malpractice case, I have to establish, or the plaintiff has to establish, there is a deviation from the standard of care. Basically, the surgery that was performed in an unreasonable manner. An informed consent case is separate and apart because I can establish that the surgery was done correctly, but if plaintiff can say you didn't give me enough information for me to make an informed decision, that case still makes its way to the jury. So what's the minority view? Not surprisingly, it's the direct opposite. And so this is a Wisconsin case, and I think this goes to the other extreme. And in that particular case, it dealt with sort of clipping an aneurysm. And that particular doctor had not performed the procedure before. And the appellate court said three things needed to be communicated in that particular case. And I think this is simply over the top, and I actually highlighted it just so we could point it out. First, the appellate court said the doctor had to divulge the extent of his inexperience in performing the operation. Second, which I just find fascinating and a really big leap in understanding of the law, they said the doctor had an obligation to compare the morbidity and mortality rate of the procedure being performed in the hands of an experienced versus an inexperienced physician. And third, the physician had to offer the plaintiff the ability to be referred to a tertiary care center where there are more experienced physicians to perform the procedure. And so that ends up being the minority view, where there's an obligation to communicate everything, your experience, mortality, morbidity rate, everything. And that's the minority view. And so the question is, where does Florida fall into it? And I call this the black and white because Florida has a statute as it relates to this. It's 766103. It's a medical consent law in Florida. Most of you are probably familiar with it, even if you've never been in litigation. It functionally says those three key pillars need to be present. You need to explain the nature of the procedure, explain the alternatives, and explain the risks to a degree that the patient would understand. And it also says if you have a written consent form that meets these requirements, it creates a rebuttable presumption that you obtained appropriate informed consent. So taking all that in mind, you would think Florida clearly adopts a universal / majority view. And I think they do, and I sort of qualify that. If you don't mind moving one more slide. So this is the gray area. My office, like I said, we try a lot of medical malpractice cases. We had our shareholder meeting today. There are a lot of cases coming in. As much as we appreciate the work, we probably appreciate if folks were not suing as much. So we see a lot of cases in our office, and we've dealt with a lot of informed consent cases. And one of the ones we dealt with recently made its way to the appellate court. And this was a prostatectomy case where, again, it is a robotic version of the procedure. There is an allegation that, and the case is Yentes versus Papadopoulos, if you guys ever want to look it up. The allegation is this physician, relatively new, I believe at this point, maybe 3-4 years out of fellowship, really, really well-credentialed, well-trained, trained at Mayo, really well-credentialed, but had never performed the robotic prostatectomy on a person at that point in practice. And the question in that case was there an obligation on the part of the physician to communicate that information? And you would think if there is an appellate case on it, then the question was answered. The question was not answered. The court made a ruling exclusively on a legal issue. The court said at the beginning of the case, the trial court could not make a decision one way or the other. It's a factual issue that needed to be developed. And so from that opinion, you may read into the fact that, well, it's a live question whether you need to create or communicate your experience because the court didn't affirm this case needed to be thrown out. But the court sort of waffles back and forth and puts this caution at the end of the opinion. And I'm going to read it, and it says, "We caution that this opinion should not be perceived as a comment on the merit of plaintiff's case or defendant's defenses. Our holding should not be construed as requiring a physician to disclose the number of times he has performed a specific procedure in order to obtain a patient's informed consent." That is really reassuring, except if they fully adopted that view, they would have affirmed the trial court's decision to throw out the case. So they said the trial court was wrong in throwing out the case, but we're also unwilling to say they were completely wrong and saying that doctors don't have to communicate this. So it literally is the gray area where you can read this opinion any way you want. And so my
Great.
guidance,
Will, that's the great legal explanation to everything. It depends.
it depends. And if any attorney tells you 100% yes, 100% no, walk out of the room.
So for our young practitioners, do you recommend not shaving, leaving some gray in your hair? I mean, because it makes me, like, kind of skeptical and a little bit biased towards individuals who are younger in practice. All the trainings, all the CAT courses, cadavers, labs, you got to start somewhere. And you're right, being in these situations, it is a very common question that we hear of, saying, well, how many times have you done this? And you feel really under the spotlight because you think it'd be like riding a bike in a sense, taking a break for certain situations. In that regards, I do have a question about documentation because sometimes it is lacking. Perfect world, would you rather have the consent done in office with the patient as well as preoperative at the surgery center? Or do you feel like that's too much duplication and confusing and just, we're a consent happy world where we're signing paragraphs and not really knowing what we said, but we said that they signed it, so we're covered?
That might be the easiest question I get all night. In a perfect world, I want both. I want the consent form signed at the office. I want several days in between, and I want a consent form signed at the surgery center. Because what that evidence is an opportunity for the patient to consider all the options that have been communicated to him or her. And so that's why it's important. I'd much rather have that. And I do appreciate that. And I'll probably, and I know we're running late, so I'm going to end here. My next slide covers it, but ultimately, if we live in the gray area, what do we do to protect ourselves? And it's exactly what Dr. Miller said. We've got to communicate to our patients. And part of that communication includes candor. If you've not done the procedure before, you can phrase it in a way, I've been trained on it, but you would be my first patient that I'm doing it with. You've got to be candid with the patient, and you've got to communicate with candor. The other thing I always recommend is provide alternatives. If this is a procedure you want to perform, saying you've not done it before doesn't close the door. What I would recommend is, this is the procedure I recommend. I am comfortable performing it based upon my experience, but have also performed alternative or other procedures to address the pathology. So you give the patient the choice. So now they're the decision maker when it comes to that. And it also protects you because now you've got it documented that you communicate your experience to the patient, you gave the patient alternatives, and the patient wanted to go forward with a procedure you were less experienced with because it provided them the potential for a better outcome. And then the final part is you need to document all that. Having that conversation, communicating with the patient, having that colloquy is fantastic. If you don't document it, Dr. Miller is right. The first thing the plaintiff's attorney will say is, if it's not documented, it did not happen. Is that true? Absolutely, positively not. It's the biggest lie that is told in medical malpractice cases, but it's been said so much, it becomes the mantra for all these cases. If it's not documented, it did not happen. I can push back on it, but I'd much rather have the paper documentation, and I can use that in the courtroom, and the case becomes even more defensible. I know we've got that at 9 o'clock, so I think we just ended right there at 9 o'clock, but those are my thoughts, piggybacking off what Dr. Miller talked about.
Well, thank you, Will. I don't mind, Larissa, if it's okay with you guys, if we go a little bit longer here. I mean, for some questions and answers and so forth, or is there a hard stop at 9 o'clock?
I don't know how many quarters are in the machine, as Karen typically says.
Dr. Schmidt, I put enough quarters in till 9:30.
Ah, perfect. So how about questions from the field, Larissa, anyone or yourself or anyone listening? And I've got others, but I don't want to I don't want to monopolize the conversation.
So if there's any hands raised, please throw them out there. I do have a question talking specifically to our younger or even more experienced practitioners. You know, every once in a while within these more complicated cases, things happen. Mr. Van Cole, what would be your recommendations to surgeons when something happens intra-op? Like, what would be your mindset as far as how to address a potential complication where there might have to be a shift, pivot, or twist mid-procedure? And I know, but go ahead. Just
Yeah, no, but I think what we talked about sort of addresses that. It's the documentation of it. And I think the way I would phrase it is you described the complication that happened in the procedure that required a different course to be taken. Describe it in detail, describe it with clarity, because if there is a complication, that's usually when cases develop. And so you've got to author your op note as if a jury may read it one day. And once the procedure is over, you try to mitigate the possibility of a lawsuit just by being candid with the patient. And part of being candid with the patient is like, there's a complication that developed. It happens during the course of the procedure. We were able to identify it. So describe yourself in a proactive way. We're able to identify it. We're able to address it. What does that mean for you over the next 2 weeks, 2 months, 6 months to a year? You communicate that as well. So you now have sort of managed the expectations, communicated the complication, and described yourself in a proactive way in addressing that complication. Hopefully that addresses what you're asking about.
yeah, I know amongst surgeons, a lot of times too, we'll like try to call family or someone in between. So to your point, it's more or less documenting the stuff that we're probably naturally inclined to do. We do have another question from Dr. Masri. If you'd like to unmute and go for it.
Great lecture, guys. I'm sorry I'm not going to talk my camera. I'm in my pajamas. But I did want to just add something. I find that, listen, we're all surgeons. We all have complications, whether they're small or large, irrelevant. The biggest thing that I've noticed in my 30 plus years of practicing is you have to show empathy when something goes wrong, or when your patient comes to you and says something's not right. Communicate, don't ignore it, try to fix it. I think that would be my little pearl that I wanted to add to that. A lot of times patients are going to sue you, not necessarily because you did something wrong, but you didn't listen. We didn't listen to them. We didn't empathize with them. We didn't you just have to listen and be empathetic. If I would say that to all my students and all the residents that we train, listen to your patients when they come in and try to be as empathetic as possible. Nothing more.
Great point. Any other questions out there? If not, we'll keep firing them. Luke, did you want to jump in with a question?
Yeah, I did. Will, I wanted to pivot back to your slide where you were talking about the black and white and the majority view and the minority view. And it made me wonder, in your world, when does the necessity fall on the doc, or is it ever talked about in these legal cases about determining the cognitive ability, or perhaps detecting cognitive decline within the informed consent discussion? In other words, does that ever come in? Like, it seems like in the last 15 to 20 years, I mean, certainly Alzheimer's disease, but all sorts of, again, back to a spectrum of cognitive decline. Does that ever factor into informed consent for you, for example, in your firm, defending informed consent conversations or allegations at lack of informed consent? What do you have to say about that cognitive ability of the patient?
Absolutely. It matters. It 100% matters. If there is an indication from your perspective that there may be difficulty by the patient in understanding what's being communicated, that factors into the consent conversation. I would argue, again, if I'm on the other side, I would argue the patient lacks the mental facility or mental capacity to understand. That vitiates any consent conversation. The consent conversation isn't a chance for you to talk, it's a chance for the patient to understand.
So if I guess maybe to be a little clear of what I'm thinking, if we were to reverse engineer it
Mhm.
Have plaintiffs' attorneys been successful in saying after the fact, you know, doc, you missed here that this patient had some sort of cognitive decline during your informed consent conversation?
Yes, yes. And this is, and I hate describing the legal process as a game. This is the game this is the game that's played. It's, can you get it to the jury? They don't have to be right. They just have to make it mushy, gray, undeterminable enough where a judge isn't going to throw it out. That's their one goal. Because once they get it to the jury, it becomes an issue of sympathy. Then you've got 6 lay people saying, how the heck did this physician who's seen this patient a dozen times, saw this patient 5 years ago where he or she clearly could understand, they should have appreciated cognitive decline. How did they not get it? Well, they missed that. What else did they miss? And
There you go. There you go.
and so that becomes the game they play. So they'll argue the consent conversation, despite what I read to you in 766.103, despite what that law says, let's look beyond it because we need to look towards the mental capacity of the patient.
Along
Okay.
certain lines of that too, I did want to throw it out there in regards to communication. As physicians, when I say, Mr. Van Cole, I'm doing this procedure on you, you know, cost wise, documentation wise, it's a CPT to me. So when I say I'm doing an arthrodesis versus an arthroplasty versus an external fixator, do you recommend consents saying it via our CPT, which is what relays to what we're signing them up for and what hardware is needed, versus layman's terms?
So this is where I think there may be a little bit of divide between the form and what may be captured in your office notes. I'm okay if the consent form uses the technical terms. If you're using an arthrodesis, arthroplasty, as opposed to a fusion or implant, I'm okay if the consent form says that, because there's rules for the surgical centers of hospitals where you might have to use the technical name. But the way I would say you would protect yourself is within your office note. When you talk about what was communicated to the patient, you would say, I communicated to the patient that this procedure was going to perform. I explained what the procedure entailed. I asked the patient, do they have any questions? Did they understand what I communicated to them? The patient affirmed that they understood and wanted to move forward with X. So I think that's how you capture both, where you have some obligations with the surgery center where you have to use the technical terminology, but within your office note, you may be able to capture sort of the layman language where, again, if 6 folks with a voter registration and a driver's license in your county is sitting in a jury box, they can understand that, yeah, if my doctor said this to me, I would know what he or she was talking about.
Very good. Dr. Masri, is your hand re-raised or is that still up from earlier? So,
Sorry from earlier.
no problem.
So
So
Larissa,
we-
I have another thought that I'd like to tie together from the 2 talks. So Will mentioned the importance of alternatives, and Tim, I want to kind of give you a chance here on the clinical side. So what I see frequently in my day job, and then also, of course, in private practice, is what I would call the necessity of documenting either the patient's goal of the outcome of the procedure, or what sort of functional outcome or functional loss have they had. So I would love to hear how you do that, because to me, I've always liked to say to patients, what is your foot no longer allowing you to do? Right? So then I can get a functional reality about where they are. And then within those alternatives or what they decide on, you can get on paper in their own words sort of what their goal is of the outcome. So when you're dealing with complex procedures, which again is the real nature of this talk, let's say total ankle joint replacement versus a fusion, or maybe you've got another idea, or arthrodiastasis or something. How do you deal with that? Do you ask them those specific questions? What's your process?
That's a great way to look at things, and I don't necessarily ask those directly like that. What I when I document or when I ask the patient, they come in with their chief complaint. So, for example, like a Charcot, rocker bottom foot ulceration. So, talking with them, I say, well, I always ask them what their goals are, and their goals are, in those certain cases or dealing with other situations, is just to be able to walk again without fear of breaking down, fear of reulceration. So, if we decide to do some type of Charcot reconstruction, I speak with them saying that, well, my goal would be for you to get into some type of braceable foot that you can walk on and hopefully not reulcerate. And when they agree that is their goal as well, that's when in the plan, that's when I say that's an indication for surgery because patient wants to get back to doing X, Y, and Z. So I guess like you're kind of looking at it the same situation where you're kind of doing it one way and it would do the other. But at the end of the day, yeah, I think having their goals in your mind and putting those goals down can solidify your thought process and I guess push you into a way where if complications do happen, you did pick that surgical procedure for that outcome. So it's more of a solidifying your plan and thought process at the end.
Thank you. And I'll just reemphasize, particularly to young practitioners, document what their foot is, what they have. What are you no longer able to do, or what have you stopped doing that you like to do because of your current foot condition? Because then you can even go to a more simple procedure like hallux limitus, hallux rigidus, where there was a runner, tennis player, so forth. We see cases where they come back later. Will probably got a bunch of these. Well, now I can't do X, Y, and Z. And you can say, whoa, 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 wait a second. We've got documented right here in the record that your functional limitations, and one of the reasons that you decided to go ahead with the surgery was because you couldn't do X, Y, and Z. But again, if we don't have that, again, my little line there, we'll never know the answer to the questions that we don't ask. If we haven't ascertained that on the front end about what their foot no longer allows them to do that they would like to do, which is one of the reasons they've arrived at an informed consent conversation and a decision to pursue surgery versus simply continue on with conservative care, then we don't have that to fall back on later when something goes sideways. So I want to just emphasize that from my own perspective as a clinician, surgeon, and in my current role. Will, do you have anything to add to that you would say is a bullet point for young practitioners?
Yes. One, I've actually tried a case where that actually came into play because obviously a big portion of these cases relate to damages. And the damage question functionally is what are you unable to do today that you were able to do prior to the alleged negligence?
There you go, right?
And that's how damages are measured. So you need to know what the limitations were preoperatively. I know a lot of these are going by the wayside. If you can fight to keep patient-filled intake forms, fight to keep them in your chart. The case I'm talking about, the intake form was signed and filled out by the patient. The patient wrote, unable to squat, unable to walk long distances, unable to climb stairs,
Bingo.
pain 7 out of 10. And so initially, when we asked the patient some of these questions and leading up to trial, and it was captioned in our doctor's note, she questioned the validity of the doctor's note. But in trial, we were able to publish her handwritten entry in the intake form saying, look, you were being candid and honest at this point, right? You didn't think you were ever going to be in a courtroom, correct? You wanted to be honest with the doctor to give the doctor as much information as possible. Yes. So we should believe this is the most honest and accurate representation of how you were prior to the doctor's care. The answer has to be yes. So if you can capture those limitations, it really helps me out. It really helps me out.
I love that, Will. And in fact, I'm going to add one other thing on that. I recommend folks do a simple visual analog scale on every single visit and have every single visit. Right on that initial intake form, you'll have patients who come into the office. It's the first visit. They've got heel pain. They say it's 10 out of 10. 3 years later, they're suing you and they say, well, it never really hurt me. And you're like, well, that's not exactly correct. And then let's go to the interim. You know, you've been treating them, and if you have them do a visual analog scale, which takes about 3 milliseconds with the little smiley faces or the sad faces, every single visit, then all of a sudden you see in the record, well, you were down to a 2 out of 10 when we last saw you, and we haven't heard from you in 8 months, right? And so now all of a sudden you can, you know, blow a lot of holes through the plaintiff's stories that way.
Sure. And we do have another question from Dr. Karbasi.
Thank you, and great topic, great lecture. Thank you everyone for taking the time tonight. This is more for our law panel. You know, being in Florida, a lot of slip and falls happen. Somehow I didn't think it would happen as much as it does in Florida, but you get a lot of patients who come to your office, they already have a lawyer. A lot of the times you get patients who are pushing for surgery, but in the instances where you find the lawyer is almost pushing for the surgery and you're getting their offices calling and saying, are you scheduling the surgery? When is the surgery? But from your clinical interactions with the patient, they're not very interested in it. They're not in that much pain. It's not warranted. Do you recommend having a phone call, person-to-person conversation with that lawyer and see what's going on? Maybe what the patient is telling you is different than what they're telling them, or just keep it closed doors, send them your notes, don't bother.
So my guidance would be this: your patient guides your care, and what you're saying is accurate. The patient is communicating to you information that leads you to believe that surgery is not indicated. That should guide you. You should also protect yourself from the attorney being upset at you, pointing their tentacles towards you. I wouldn't always recommend calling an attorney, but I think a good phone call is to call the attorney saying, look, my notes indicate that this patient doesn't really need the surgery. And I think if you read my notes, it's going to say that. What I don't want to put in my notes, and you can have this conversation with them, what I don't want to put in my notes is the attorney has called me and said the patient may need surgery, because that will submarine a case like no one's business, because it now looks like the attorney is directing the care. So I think it would help you, if you ever need to make that phone call, to call the attorney and be candid with the attorney. It's like, look, I've documented everything that I've needed to document. What I've not documented is our conversations. I don't think the patient needs the surgery. And if the surgery is pushed for, I'm going to have to indicate why my notes at one point said surgery was not indicated, and now the patient wants to have the surgery. And your phone call is important and material to that. I'm going to have to include our conversation as part of my notes now. And that usually will stop it.
Awesome.
That's
Thank you.
great advice, Will. Thank you for that, for everybody.
There were just two more points I wanted to make as well too. What I've noticed has helped me is actually including clinical pictures in my documentation as well. You know, whether it's hammer toe bunion, ulceration, deformity, um, because I think that has aided in showing at the end of the day the need, if a complication arises, why you ended up going for that surgery, kind of along the VAS scale and kind of along what weren't you able to do before, and kind of those questions there. That's number one. And number two, speaking about complications intraoperatively, I have found that if that happens, you know, as long as the patient is stable and I've taken care of the complication, calling the family intraoperatively, maybe not necessarily waiting until afterwards, obviously, given the situation, if you have the time. But I have found that that has gone a long way with the family members, basically keeping them informed, you feeling like they're a part of the care team as well, and that has gone a long way.
That's great, Tim. That's high quality. And back to an earlier comment from one of the attendees, it's empathy, right? It's empathic listening, communication, and everything else, right? It's putting yourself in their shoes. Well, wonderful. Larissa, we'll turn it back to you. I think perhaps we can wind it up there if there's no other questions.
No, I just want to thank everyone really for their time. We are working hard from the standpoint of FPMA, reaching members, trying to find strategies to assist not only our practice, but our communities we live and work in. Thank you all for everyone, what you do. We will be having another webinar next month, so please keep the emails open and your submissions in. Thank you all for your flexibility in meeting tonight too. We kind of had a little hurricane mix up, so definitely appreciate everyone's flexibility and participation. Happy holidays. Wish you all a very happy Thanksgiving. Thank you to PICA, Mr. Van Cole, Dr. Miller for all your assistance, and as always, our graceful Ms. Karen Lambert for assisting and putting this together, as well as Ms. Becky Sargent. So I hope you all have a happy holiday season and a blessed evening.
Thank you, everyone.
Thank you.
Thank you very much. Thank you all. Have
Bye,
a great
everybody.
holiday. Thanks, everybody.